Thank you, Dr. Anshika, and thank you to the IRSI executive, Dr. Himanshu Mehta, sir, and also the Youthful IRSI led by Rohan and Pooja. And so I would like to just start sharing my screen. I'll be speaking on changing paradigm in VR surgery. So I like to start my talk with this picture. And so for all of us who trained long back, maybe about 20 years back, we were very used to doing scleral buckling. And these are the gory pictures which one can, actually see all the buckles and all the explants which are there. And in fact, I've also assisted implants when I was trained at Shankar Netralaya. And mind you, that was a very time consuming, very gory, as you can see. Then came the pars plana vitrectomy, and the first pars plana vitrectomy was described by Macamar way back in the 70s. And initially there was a single instrument, and then came the 3-port pars plana vitrectomy by O'Malley. And then came the sutureless vitrectomy system, which was initially introduced by Chen, and then Fuji, who gave the 25 gauge sutureless vitrectomy, and Eckhart, who gave the 23 gauge sutureless vitrectomy. So initially there were some issues with the rigidity of these instruments, but the newer 25 gauge plus and 27 gauge plus probes and instruments have a stiffening sleeve, which has overcome this problem. Wound construction was also initially an issue, but then it was found that when we made oblique incisions, then it was better. Surgical time, it did not really change the surgical time much, because the time you saved in going in and coming out was actually spent during vitrectomy, because the vitrectomy times are a little more with the MIVS instruments. Some complications can occur, like hypotony, but if you do a partial fluid air exchange, and if you are very diligent about closing any leaking sclerotomies, then you don't face this issue. Endophthalmitis, recent studies have shown that it is not, MIVS is not associated with higher rates of endophthalmitis, and retinal detachment also is not found to be more common with MIVS, and it is not found to be related to the technique itself. So initial indications for 25 gauge vitrectomy were the straightforward posterior pole cases like an epimacular membrane, macular hole, CSME, VMT. But then came the expanded indications for various kinds of retinal detachments. I won't go into the details. And you can also do a hybrid vitrectomy in which you can combine a 25 gauge and a 20 gauge instrument for, let's say removing a nucleus in a case of nucleus drop. So MIVS is here to stay, and there are various, gauges which are available, like 25 gauge, 23 gauge, 27 gauge. And this is the most popular system, the Constellation Vision system from Alcon. I don't have any financial interests. So what are the advantages of MIVS? So there is more patient satisfaction. It is more comfortable. The eye looks normal, and there's quicker visual recovery, less astigmatism and less inflammation, less operative time, and it is ideal for patients with filtering procedures. Various illumination devices have been developed by Eckhart, like the Twin Light, the Oshima, who developed the 27 gauge and the 29 gauge mercury vapor illuminations. Chandelier systems are also there, which enable us to do bimanual vitrectomy. So there are various indications for bimanual vitrectomy. And now we have the 27 gauge, which is the most recent one, and which is becoming popular now. And you have the valved entry system. So this enables us to have a closed system so that there is very little flutter of the retina, and you are able to do a safer job inside the eye. Then you also have a vent, the purpose of which is for normalizing the pressure. And this is the stiffening sleeve which I was talking about, which enables us to do surgery with these finer instruments without tool flex. And then we have this finesse, which is my preferred instrument for scraping. I used to use the Thanos diamond dusted scraper earlier, but this finesse loop is really very nice. So the Alcon Ultravit has gone on to 10,000 cuts per minute. So way back we were at very less cuts per minute, but now we have the valved 10,000 cuts per minute bevel tip. So this is the technology which actually is a game changer. So as you can see in this cross section, that this Alcon has a high speed probe which has a dual pneumatic drive. So both the to and fro motion of the cutter probe is active, not passive. And so these are the advantages, that you have fewer iatrogenic breaks, and you can have more efficient vitreous removal. And I won't go into details, but you can do diabetic surgery very nicely with these bevel probes. So the latest, the latest development is Ingenuity, which is, the 3D surgery, and in which, you have a 3D display screen, and it's a heads up surgery without any oculars, and the surgeon and the assistant. And it is also very useful for training, because everyone in the operating room can wear these 3D glasses and can have a 3-dimensional aspect of the surgery being done. So initially we were used to a picture which was like this, and then with high definition it became like this. With Ingenuity, this is the kind of change in perspective that you might have. So if you see here that you are focused on this arch here, but with Ingenuity, you can focus at the entire field. And it has been integrated very nicely into the Constellation system. And it also is definitely ergonomically much better, with 85% of retina surgeons who complained of neck and back pain, it's much better for them. So this is a short video of the Ingenuity. So you can see that the surgeon and the assistant and along with the other trainees are wearing these 3D glasses and are observing the surgery being done on the screen in 3D. So it does, totally change the perspective of surgery for the surgeon. I'll just go over to the next slide. So another game changer, which is supposed to be a game changer, is intra-op OCT, which is actually integrated OCT into the microscope from Zeiss. That is one of the machines which has it. It's the Rescan 700, and it is very useful for simultaneously.
I didn't get that. Could you try again?
I'm sorry. So IOCT is very useful for integration with the microscope, and you can visualize the epiretinal membranes simultaneously on the OCT, and it is useful for monitoring vitreous traction during macular surgery, also to see where the membrane edge is. So while doing epimacular membrane peeling, you can look for the edge of the membrane using the intra-op OCT. So some new developments, as Dr. Lalit Verma sir was also telling, with the bionic eye, which is from second sight. It's a retinal prosthesis which bypasses the damaged photoreceptors with a mini video camera housed inside a pair of glasses. The camera sends signals to an implanted chip near the retina, which stimulates retinal cells and produces visual light patterns. So this system is supposed to work only for people with conditions like retinitis pigmentosa, because the disease only damages the eye's photoreceptors and leaves the retinal cells intact. For these patients, the retinal prosthesis is effective enough that they can recognize objects, see people, and follow movement. So it just gives gross vision. So I'll just go to a few of my cases. So this is a lady with the pre-op vision of 3/60, and you can see a full thickness macular hole in the right eye. And this is a 27 gauge macular hole surgery, which I've done for this patient, and I'll be doing the inverse ILM flap. So just initiating the PVD, then IVT. And then just peeling the ILM in flower petal appearance, and just getting all these flaps to oppose onto the macular hole. So this just ensures that, this technique is mostly used for large macular holes. And then doing a careful air fluid exchange with C3F8 gas tamponade. So this patient got a vision of 6/60 post-op, and you can see that the hole is nicely closed. So another condition where MIVS is very useful is the 25 gauge, optic nerve head pit maculopathy. Had best corrected vision of 6/18 in the right eye with optic pit maculopathy and foveal thinning due to chronic neurosensory detachment and retinoschisis. She underwent IVTA-assisted 25 gauge vitrectomy. DBG dye-assisted juxtapapillary ILM peeling with apposition of peeled ILM over optic disc pit as opposed to a macular hole. The apposed ILM in optic disc pit has a 30-year-old lady with retinoschisis. She underwent IVTA-assisted 25 gauge vitrectomy. DBG dye-assisted juxtapapillary ILM peeling with apposition of peeled ILM over optic disc pit as opposed to a macular hole. The apposed ILM in optic disc pit has a tendency to remain plugged inside the pit due to negative suction pit, air fluid exchange, and C3F8 gas tamponade. At final follow-up at 18 months, best corrected vision had improved to 6/9 with complete resolution of neurosensory detachment. This is another case of posterior dislocated multifocal IOL, which was managed with 25 gauge MIVS. And you can see that, that is the IOL, which the vitrectomy is done initially. And once the IOL is free, I'll be picking it up with a forceps. And these are the 25 gauge trocar cannula system. And with the handshake maneuver, I'm transferring it to the other hand and then making an entry into the interior chamber. And without actually explanting the IOL, I was able to just relocate it into the sulcus. And thankfully, there was good centration, because again, with multifocal IOL, you want good centration. This is a case of live intravitreal cyst.
Fundus showed live intravitreal surface cyst with retinal detachment with severe PVR. Ultrasound B scan left eye showed an oval hyperreflective cyst with hyperreflective scolex and incomplete PVD.
So I think there's some issue with the video.
Under topical and oral.
But basically, I did an encerclage band for this patient.
Conjunctival peritomy was done. Stat, scleral tunnels made in 4 quadrants and passed in stored with closed hitch knot in the supratemporal quadrant. 25 gauge MIVS surgery was done. We can see the remarkable undulatory movement of the cyst as vitrectomy is done.
So you can see these sieve-like holes which the the scolex had created, and finally the cyst was eaten in total inside the eye.
Scolex of the cystic circuit. Finally,
I'm sorry about the
have a cause by
stopping.
So
you can see the scolex here. You can see the scolex once the cyst is eaten inside the eye.
Out once the cyst is eaten with the cutter. Extensive endolaser was required. Silicon oil was injected. Silicon oil removal was done to remove extensive epiretinal membranes over the posterior pole and internal limiting membrane over the macula. At final follow-up at 1 year, best corrected vision was 624 parts. PCL was in situ with central PC opening. Fundus showed attached retina with extensive peripheral scarring in the area of laser sparing the macula. OCT showed flat retina with resolving minimal macular edema.
And this is my last video of a giant retinal tear with retinal detachment. Again, managed with 23 gauge. So with that, I just finished my videos. I'm not sure if I have a couple of minutes or a minute more, but I just had pulled out these few studies because Rohan wanted me to talk about the visual outcome per se and the changing paradigm. So, this is a recent study which just said that, the PRO study report number 9, which says that retinal detachment with inferior breaks has a higher single surgery success rate if treated with PPD and scleral buckle combined. So still there is a role for scleral buckle. So this is a study of long-term outcomes of 27 gauge vitrectomy, and which showed good results with 27 gauge vitrectomy for most of the posterior segment conditions. And all these MIVS 25 and 27 gauge were found to be useful for conditions like epiretinal membrane and full thickness macular hole. And earlier we had these studies about 15 years back on ROP, and now we have studies of MIVS in ROP surgery with good results, showing good results. So MIVS is being used for most of the conditions now. These are a few studies on heads-up 3D viewing. This one is from RP Center, and another one from the Arvind Eye Institute, which showed that anatomical and functional outcomes of surgery were favorable with this heads-up surgery compared to the conventional microscope surgery. And also it gave rise to better ergonomics. And bimanual vitrectomy with MIVS was good for diabetic retinopathy. This is a study from Eye Center. And also we have studies, of scleral, without doing scleral depression, the wide angle viewing system are very helpful, and we don't even have to do much of scleral depression nowadays. So with that, I come to the end of my talk, and thank you so much.